And we're back with Marc Surdyka. Marc was on just a few episodes ago to help me out with the Total Knee Replacement podcast, but we're back with a debunking episode, which we haven't done. I was looking at the last episode and it was January of this year, so almost a year ago. Welcome back, Marc. We are going to dive into kind of the big topic of continuing education courses. But for people who haven't listened to these debunking episodes in the past, I've really enjoyed them. And I think other listeners have. So if you want to go back and listen, I think we have 5 at this point. So this is the 6th one. We did one on core stability, leg extensions, imaging myths, gluteal amnesia, and shoulder impingement. So I'll link all those below. But the goal with these is to just provide maybe some pushback of common narratives or views or beliefs on a variety of topics. And today it's going to be on continuing ed courses. And I can share my story of a specific group or course, but really we want to kind of zoom out and look at what are things that students and new grads and clinicians should look for in regards to red flags or things that maybe they should be skeptical with courses, and what things they should look for as beneficial courses. So let's just dive kind of right into it. I think a good spot to start is kind of this, I would say, common journey of a student or a new grad. And I want to share part of my story or experience that may resonate with some individuals. But I think it's really common, whether you're a personal trainer or an S&C coach or a physical therapist or another rehab provider, where you're in undergrad or grad school and you really start becoming passionate about a topic or about your future profession. And you may be young and you're trying to start diving into resources and people to learn from and groups to learn from. And there's potentially, right when you get started, this lack of direction of learning information or taking in information. And with that lack of direction, you may be doing this on your own. And there's kind of a lack of guidance as well, where you're kind of aimlessly looking on YouTube or Instagram or social media, or maybe you're trying to read research, but there's really no directionality and it's kind of aimless because you realize, oh, I'm really interested in this area of training humans or rehabilitation, but you don't really know how to funnel the information or where to start because there's so much. There's also maybe this lack of skepticism where, because you may not have a baseline understanding of a lot of these topics or really any prior knowledge besides maybe your own personal experience going through rehab yourself or just training yourself, that you don't really have a skeptical eye of the information that you're taking in. And then kind of a fourth thing I listed is this potential lack of mentorship with someone that's not providing some opportunity for you to reflect on the things you're learning and providing maybe that skepticism that you don't have. So I think all of those just are natural when you're starting to learn, especially as an undergrad or even at the beginning of grad school, where it can lead to interesting paths and places for you to end up in. And some of them may be really beneficial and you find phenomenal people to learn from and mentors and groups. But oftentimes there's a lot of not super helpful information, not super helpful groups that you may find yourself in. And we're going to talk about some of that today. So I will kind of give my perspective of what it looks like for me when I was going down this path of being an undergrad, trying to learn as much as I could about a variety of topics and training and exercise physiology and rehabilitation. And this was 10 years ago. So I was 18. And I don't know, I'm curious to hear your perspective, Marc, but I don't know if nowadays, 10 years later, if things are potentially easier for an 18-year-old or someone starting their undergrad education or maybe starting their first year of chiro or PT school, if there's a better starting point for them, or if it's even more chaotic because there's even more places someone could go. But for me, I was 18, diving into a variety of coaches and podcasts and articles and videos. And I ended up finding myself in this PRI exploration. And for people who aren't familiar, this is just a group. PRI stands for Postural Restoration Institute, and it's based out of the Midwest. I forgot where, maybe Wisconsin or somewhere else, but this guy, Ron Hruska, created it. And I was following these really great strength conditioning coaches, but they kind of fell in love with PRI and utilizing some of the concepts and principles in their own view of training and interacting with athletes. And during undergrad, I spent hours and years in the school library, not studying for classes, but taking these like remote PRI courses that really were so confusing and so all over the place that I felt so kind of dumb and limited in my knowledge when I was taking it. But I thought, okay, this is the answer. If I really understand these principles and these concepts, that it's really going to set me up to be a great coach or a great physical therapist. And I did kind of that consistent education process, learning from coaches, taking these online courses, until I graduated from undergrad. And then I shared this story in other podcasts, so I won't talk about all of it, but spent that summer between undergrad and grad school in California. And part of my mentorship was with Derek Miles at Stanford Children's, and he's with Barbell Medicine now, but he really just kind of flattened my views and some of my strong beliefs on this topic and on the course and on this kind of model as a whole. And it provided me such a great perspective on how to be more skeptical, how to kind of zoom out and look at other theories and critically think through things that I'm learning. And that's kind of the goal today of how, as a clinician or as a student, or even as, someone just generally interested in these topics, trying to take in this information. What are things to look for? So we can kind of clump a lot of these courses or groups together, and I don't want to single one out, but I at least wanted to share my perspective of what I went through in this kind of PRI education model. But this can apply for so many different groups or individuals that you can kind of use some of these recommendations broadly. So I think I wanted to talk about some of these common themes across a lot of these continuing education groups that may be considered red flags or things that you should just look for if you're diving into a topic or wanting to take these courses, either seeing and looking through their other materials online or other resources, or if you're in person taking the course, what are these things that you should kind of ask yourself or look for as being potentially red flags or things to be concerned about? So
before diving into that, Chris, just because you spoke about a lot there, and I'll try to chime into a few questions that were directed toward me. Maybe it was rhetorical, but when I was 18, I probably didn't have the same thirst for knowledge that you did. So your experience going into undergrad versus my experience going into undergrad, I cared about, am I doing well in school? Am I working, my jobs or whatever to help support myself? Am I having some fun? I probably wasn't, especially my first year, I wasn't thinking about physical therapy. I was a business major. And even when I switched to kinesiology, that wasn't at the top of my mind. I had other priorities in my life as an 18-year-old, 19-year-old, 20-year-old. Like I said, I probably didn't have the same thirst for knowledge as you. And then you asked, is it harder? Is it easier? Is, better or worse for 18-year-olds now versus before? And I would say it's harder and easier. It's easier to have access to this information, but it's harder to know what information is worthwhile. And I know that you want this conversation to be more about continuing education courses and what to look for in those courses that you take, but this is a much broader topic as well, just with the amount of information that's available to people via podcast episodes, YouTube videos, Instagram posts, etc. And so it can be difficult to navigate. And sometimes when I do the Q&As on the E3 Rehab Instagram page, people ask me, how do you keep up with all of the research? And my answer is that I don't. It's not possible. And I think sometimes these younger clinicians feel that they have to find the answers and they have to find the answers quickly, when in reality, it's a never ending learning process. And so it can be difficult when you first leave undergrad or you first leave, PT school, and you want the answers. And we give these disclaimers for all of these types of episodes. And like Chris said, we're not trying to take a dig at any one specific course, because we could talk about just broader things in general as well, meaning that you come out of new grad and you go, manual therapy is going to be the thing that does it for my patients. And then you hear about, pain neuroscience education. And you go, okay, I'm going to go all in on pain neuroscience education. And then it's something else. And so I think, and Chris can correct me if I'm wrong, it's just trying to understand what value you can take from some of these Con Ed courses maybe, and what to look for in the Con Ed courses that you do take. So yeah, Chris, I guess if you have anything to add to that, feel free. Otherwise, I guess we'll go into what you had listed.
Yeah, I would just say I agree. I think this is looking at it from a view of continuing ed courses, but this can be utilized when you're looking at someone's social media page or their YouTube or their podcasts, or even talking with coworkers or other students, things to just ask yourself or to look for. So the first one I listed is speaking in absolutes or always having an answer. Unfortunately, a lot of these courses, there's this sense of there's a black and white for a variety of things that they're teaching. And if a question is asked, there's always an answer to that question. There's really no gray, there's no uncertainty, there's no just saying, I don't know, or I'm not sure. There's always going to be an answer, or there's always going to be a solution based off of the model that they have. And I think that's really something to be wary of or to be skeptical of when there's always a black and white. I think that's a really common one that you'll see in a lot of these groups, or like Mark said, it doesn't have to be just continuing education, but in people speaking about a topic, even if they're experts, probably actually the more of an expert that they are, the more they may speak in uncertainties or in some gray and less in absolutes. So I would be cautious of individuals or groups or these continuing ed courses talking about everything as fact or as black and white. This is true, or this is the way that it has to be done.
Building off of that, Chris, I'd say that if they only talk about successes, and it sounds like they only have successes, like they have a 100% success rate, that should immediately raise some alarm, some red flags. Everyone's going to have failures, whether you want to call them a failure or not. Things just might not go the way that you expect as a clinician, as a coach, as a student. That happens for us as well. And we understand that there is no 100% predictability. So if somebody is always saying, well, a person presents like this, I do this, and this is the response, and they always get better, that's, probably not going to be the case. I'm not a fan personally of live demos. Like, let's say I'm teaching a Con Ed course. I ask if anybody has shoulder pain. Chris raises his hand. I tap his right earlobe, and his, shoulder pain gets better, and everybody is amazed. And we know that you can have some of these short-term changes in pain, but there's so many things that would influence that interaction, not just like that dynamic between that provider and the person in that room, but so many other things that I'm usually not a big fan of those live demonstrations. And some of this goes, you might be too young for this, Chris, but it's probably like a craze in the 2000s. And I know that some Con Ed providers have actually made fun of it, but there were these magnetic bracelets that, let's say you'd be walking around an indoor shopping mall, some guy would call you over and say, hey, try on this magnetic bracelet. And then he'd have you stand on one leg, raise your arm out with the bracelet on, and then go, okay, hold. And he'd push your arm down really quickly, and you'd lose balance, obviously, because you are unprepared and he's pushing really hard. Or he did that before the bracelet. I'm sorry. So no bracelet on. He has you raise your arm. He pushes down. You fall over. Then he goes, okay, try this bracelet. He puts the bracelet on. You stand on one leg. You put your arm out. This time he gradually ramps up his force. You know what's coming. You're a little bit better prepared. Your balance is better. And then, hurrah, this magnetic bracelet is like the thing that changed your nervous system or something, and those are some of the things that we see in some of these courses. Did you ever see those? Are you familiar with that?
Yeah, that's a flashback because I remember it was like the cool thing to wear as a kid. And then it reminded me of a patient that I was recently working with in person that was wearing it. He was probably, I think he's in his 60s, and he actually fell and hurt his knee pretty badly. And he had to cancel one day's visit. But now that I think of it, I think that's so ironic that he's still wearing that bracelet, and that did not help with his his balance in that aspect. Yeah. I think another thing to that point of that kind of test retest in this group setting where the teacher or the practitioner is taking someone through it. I think it was Greg Lehman who shows this video a lot in his courses, but I think other clinicians have done it where it was another course or it was some lecture where this individual had someone come onto the stage and was trying to show them how they could visually distinguish which shoulder was painful based off of kind of their scapular position, their scapular dyskinesis. And he was super confident in discussing, like, you see how this is moving in this direction with both of their arms elevated or both arms elevated. This is what it's going to be. And then after just minutes of kind of going down this dialogue, the individual that was on stage was like, actually, it's my other shoulder that I've had persistent symptoms. And it shows that a lot of these, absolutes or things that either you're visually looking for or that you're manually changing, it may not be accurate. Or like Marc said, it's these very just short-term changes in, either acute range of motion or transient symptom relief that's not inherently that special. And you have the effects of if you're the person being tested on, you're maybe biased to say certain things because you're in front of the class, or you are strongly going to believe that XYZ was helpful. Number two, so first one, speaking in absolutes, always having an answer. Number two, not utilizing research or cherry picking studies. This, I think it's messy because in part of the later on in our conversation, things to look for, I said evidence-based information, but a lot of these courses or groups can bring evidence or put it in their slides, but if you dive into it, it may not have anything to do with the actual topic, or it may be such poor study or such limited in its sample size that it really doesn't hold much weight, that actually it should be a valuable research to utilize as kind of your weighing of why you're performing this treatment. So I think if a group is not citing any sources, or they're citing sources and you dive into it and you have this gut feeling that this is not representative of this topic as a whole, those are things that I think a lot of these groups do as well. There's the opposite where they'll throw tons of research, but it's so all over the place and it's so scattered, and you start looking through it and you realize that this isn't valuable at all, and this really isn't helping their argument. I was looking at some of these groups' websites, and they have, some of these 3-letter acronym groups, they have like a research or published section, and I started diving into some of these papers, and a lot of them are kind of case reports, commentaries, or they may be an RCT, but the RCTs are so poorly done and the interpretations are so limited to the utility of how this applies in practice that it even though there's research, it's not robust and it's not representative as a whole compared to large scale RCTs or major systematic reviews or consensus statements or clinical practice guidelines, which I think we can talk about in things to look for, things to kind of guide your practice. But yeah, I think number 2 is not utilizing any research or cherry picking studies to support the claims within this group, or throwing so much research that it's almost overwhelming and the participants believe this has to be true because they're citing hundreds of things.
Yeah, which it does make it difficult to interpret in the moment. And I think that's why it could be helpful to go back to number 1 in the sense of what is their confidence level. Like it is fine to throw a lot of research, or maybe they even cherry pick some research. But if it's, hey, this thing always happens this way when you do this because of this study, maybe your skepticism comes back. Going back to your blog and your YouTube video about ACL reconstructions and re-tear rates, your recommendation is, hey, you should probably wait 9 months or longer. But you also are not saying that with an absolute, like, this is the line that I'm drawing. If somebody returns in 8 months, maybe there's a reason for that. If somebody needs a year and a half, maybe there's a reason for that. And so it's not taking that study and speaking in absolute. So kind of going back to that number 1 can be helpful if you're not able to discern what's kind of being embellished a bit with the research that's being presented.
Number 3, I put utilizing overly complex jargon or verbiage that's not commonly utilized in the rest of the field as a whole. I'll go back again to this PRI point, and it's not because I'm solely picking out PRI as the worst compared to other groups, but it's just my experience and I was the most comfortable with sharing. So if anyone's taken PRI courses, they come up with these names for these kind of patterns that people are in naturally, and they call it these AIC patterns or these PEC or this. They come up with these verbiage that really they kind of have created, and that I think really insulates the group even more, because it's this, oh, I know this verbiage within this course, or when we take multiple courses, and we can have common language. But when you zoom out and you look at the research as a whole or other groups, they have no idea what you're talking about. And it's because it's not a standard thing across the board. And I think that's concerning, because it really makes for kind of this in-group close-knit, we have this shared language, but it's not standardized, and it's not something that's kind of utilized throughout kind of practice as a whole. So I think if you find yourself in these groups or these individuals coming up with this language that you've never heard of, and you've looked at other areas of research or practice, that I would, again, be skeptical to it. And I have an example of one of the papers that they cited in their research within their website. And I just wanted to read the conclusion. And none of this was, I would say, maybe made up terms, but just like listen to the conclusion and listen to if it makes sense or if it's confusing. Non-manual exercise techniques based upon the science of postural restoration may equalize asymmetries present in FA internal rotation and hip abduction. Improvements in symmetry of joint range of motion may indicate a restoration of neutrality of the pelvis and femoroacetabular joints. By improving anatomical alignment through establishing a neutral pelvis, athletes may demonstrate improved neuromechanical efficiency and kinesthetic control of multidirectional motions required for enhanced sports performance markers. So there's just
neutral pelvis move better.
Yeah, it's lengthy, jargony. I think it's leaping to potential conclusions or saying this may improve XYZ, but we've already discussed some of the limitations of like what even a neutral pelvis is, or trying to measure these things. But there's common themes throughout a lot of these groups. They'll just kind of, it's just word vomiting, and you kind of get lost within the sentence or within their explanation because they're throwing so much at you that, again, it may sound legit or official, but if you can't follow the steps of their reasoning, then I think that's a concern.
What do you say to somebody that says to you, well, you're just, you're not smart enough, Chris, to understand what that means?
Yeah, I think that's a common retort. And I think that really smart practitioners and educators and clinicians, even though a lot of topics are extremely complex, there's an ability for them to, in the best way possible, simplify it to make it make sense and for people and individuals to track where they're coming from and how they got to the conclusions. And they may also start to provide like the uncertainty or discuss some of the unknowns. Whereas if this is, you're not tracking this because you just don't have the adequate information or the knowledge, and this is on you, I would flip back and say, I think it's on the group as a whole or on the individual for not making this clear enough for a participant or someone learning to track the kind of subsequent steps of their reasoning.
Yeah, like you said, I think verbiage that's unnecessarily unnecessary or unnecessarily complex. I was looking at some videos to respond to in short format or like a reel format, and I came across a post where somebody said that if you're unable to feel your glutes, it's because of your poor sensory afferent feedback, and or something along those lines. And just that statement alone is, I've never used the phrase sensory afferent feedback with any patient or client ever because it's not valuable. And that alone is just a little bit of a yellow or a red flag to me if you feel like you have to use that, because then you have to explain what that means. And it's, you have this knowledge that nobody else has. A trend that I've also noticed recently, and at least on social media, is that everyone's a biomechanics expert now. But when they talk about biomechanics, they're really speaking about kinematics. And when they're speaking about kinematics, it's analyzing the way that people are moving using methods that aren't validated or reproducible. And they're moving this way and it's good, or they're moving this way and it's bad, and this is what we did and this is how it changed their movement. And we're a biomechanics expert, and there's no, you can't, it's hard to argue because I'm not even sure if they know what they're talking about or they understand what they mean when they say biomechanics. But that's a trend that I've noticed, that I've kind of seen.
Yeah, while you were talking, I was trying to find a paper that I think Derek Miles shared with me, but I think the title's like on the receptivity of pseudo profound bullshit. And it's essentially just a paper talking about the language that is either overly complex or overly jargony, and how that ends up being ways for individuals to hide the information within it that's just not truthful, or it's so many directions. There's really no actual point to what they're being said, to what they're saying. So yeah, I think number 3, overly complex jargon or verbiage that just doesn't make sense. Number 4, fragilistic frameworks and narratives. And a lot of these groups, unfortunately, you end up leaving, the 2 or 3 day class and you start feeling bad about how you move, or you start over analyzing yourself or the other participants. And it becomes extremely nitpicky and hyper aware of these very minute joint positions or patterns of breathing or these fundamental like activities that just become pathologized. And I think that's a very common theme and trend across a lot of these groups, is it becomes way too hypercritical on things that don't matter potentially as much as they say it matters. And that bleeds into interacting with your patients or with your clients, where you start focusing on these specific orientations of their pelvis or their rib cage or the way they exhale. And it seems like you're being extremely technical in your approach. But is that necessary, or is that true that they have to be in the specific position to improve their outcomes or to alleviate some of their symptoms? And I remember going down that path of like being hyperfixated on my left rib cage flare or my pelvic drop or whatever it is. And it really instills this sense of like neuroticism and perfectionism, which I don't think is necessary. And with zooming out the research as a whole, there's just so much variability of how people move, how they can perform, how they can live their life without symptoms. And there's so many ways that someone can present physically and move and be that I, again, would consider that something to look at as a red flag or to look through a skeptical lens if they're discussing these things as this has to be performed or positioned in this way or else. And it kind of snowballs into this really fragile based view of humans and of the way you should be treating them or working with them. Do you have anything to add there, Mark, before we kind of shift gears?
I think I've touched on this before, and I do so not to diminish anybody's hardships, but it goes back to what I said, with access to information, it's easier and harder. And with access to all of this stuff, it can be better and worse, and things are amplified in the sense that people still worry about their health. People still have bills to pay. We all still have these problems, but maybe they're not to the same extent that they were 100 years ago or 200 years ago, that now these courses are focusing on these little minuscule issues that we never had time to worry about now. And they're just trying, they're amplifying that. And then it's, social media is amplifying that. You're comparing your salary to the salary to a person, 5,000 miles away, and all these comparisons. And I just think that if these courses or this information is making you, like you said, hyper aware, self-conscious, you feel shame, you feel bad about yourself, it's probably not a good takeaway. You could say, hey, I need to work on my knee strength, or hey, I need to work on my shoulder range of motion, but that should come from a place of empowerment of, hey, now I have a way to work on this versus, yeah, my pelvis is a little bit asymmetrical and I need to spend every waking minute thinking about it. And every time I look in the mirror, I'm disgusted with myself, because honestly, those are the things that we hear from people, that like they don't find themselves acceptable in their own bodies because of these small, imperceptible deviations that they've been led to believe are problems.
I think it's helpful to also just caveat the idea of we're not necessarily recommending people just completely avoid some of these courses, because some of the times you just don't know until you're in it. And I think it was really helpful for me to kind of go down this path as a younger adult in undergrad, just kind of stumbling my way through education, because now pulling out of it, I can notice these things much more in other groups or with what other individuals are saying. I would say that if you are going to dive into some of these courses that maybe you're unsure of how they're going to go or what's going to be taught, you just think through some of these red flags or narratives that are being told, and then come out of it with analyzing that, and also just not utilizing that course or that group or that ideology as the end all be all, and having variability in your learning and your mentors and other ways to look at problems or injuries to give yourself options for learning and not just stay within this kind of narrow lane. I think that's the most helpful. Not having to avoid potential groups, but maybe going down, experiencing what they're telling you, having some skepticism, maybe taking away some helpful pieces that you think will be beneficial, but not completely enveloping yourself in this group and only utilizing that information to guide your practice or your interactions?
I'll give a concrete example too. So I took some of the FRC courses, and I'm sure there's some information that you could take away and use in your regular practice. But an example would be if you don't pass their arbitrary test for whatever joint, you're told that you don't have that joint, right? Like if I don't pass their hip test, I don't have a hip joint, or I have a shitty hip joint. And this is not a way to communicate with people. And the only people who could pass those tests would be one or two of the hypermobile teachers anyway. And some of the teachers couldn't do those tests. And I do recall that in one instance, one of the teachers who was, I don't know if he's probably still well known, who's known for being very mobile, was asked to present a cat cow just to show his cat cow, to show his spinal segmentation. And he refused to do it because a week earlier he had done something that hurt his back, and he was too afraid to demonstrate his cat cow because it wasn't going to be this quote unquote perfect segmentation of each vertebra. So that's kind of worrisome too, is that he was afraid to present this imperfect presentation of himself because for fear of judgment from people saying, oh, well, you can't even do this perfect cat cow. It's interesting to think about.
Yeah, it's you as the presenter or the group, they have to show themselves in the best light or to represent their own bodies in this way where that's not helpful and that's harmful. And it just is, misrepresents the goal of showing that people have certain limitations and sometimes it's valuable to improve upon them. And that's what some of this kind of standardization of an examination and a plan of care is. But a lot of times it's finding things that maybe are apparent, but do they need to change? Or is this just kind of a normal human variation or something that they've lived with their whole life? Let's go to things to look at from a positive note, whether it's individuals or these continuing education groups. What should you be looking for as a positive? And a lot of this is just flipped from what we just talked about, but there was kind of 3 or 4 main things that I wanted to bring up. And if Marc, you had any others, let me know. But I think the first one is this overarching kind of presentation of information from an evidence-based perspective. Like I said, that can just get really misrepresented, or there's ways to skew that. But as a teacher or educator discussing these topics or giving this information, you're presenting the information based off of the evidence as a whole, and you're utilizing what is recommended on a large scale kind of group. So a lot of the guests we've had in the past, we've discussed these big clinical practice guidelines or these systematic reviews or these consensus statements where a lot of really smart practitioners and clinicians and researchers have come together and had kind of a either unanimous or a majority vote on these are the things that from the research makes sense and from clinical practice makes sense for us to prioritize. And if you are aware of those things going into courses and you're being taught something that's not within that hierarchy of priorities for a specific topic or specific injury, then I would be skeptical. And if the individual speaking is not bringing up, okay, this is kind of what we know from the evidence as a whole. These are the things that are priorities, or these are the things that we just don't know, or they may work, or they don't work at all. If there's none of that kind of establishing of where does this stand within what we know and what is being researched, then I think, again, it goes to there needs to be a standard of where this information is coming from. And that's not to say that like certain courses or certain things that are being taught that don't have evidence and it's more of this kind of clinical experience or this coaching experience, that's not valuable. But if you're learning something that doesn't have any of that, there should be a caveat from the practitioner or the coach or the clinician saying like, hey, this isn't really supported in the research or it's not been studied yet, but this is just my own professional experience. And I want to give that caveat. And I have a ton of respect when I do go to courses and they do present that and they say, you know, for part of their lecture, like, hey, I just want to say that like, this hasn't been studied, but this is what I've experienced with the individuals that I've worked with. And this is what I've seen. And yeah, I think those are really big things to look for within a course. Number two, experts. Go ahead, Mark.
Yeah, I want to add to that. Evidence or research, sure, it's not the end all be all. I understand that people are skeptical at times, but there has to be something that guides your practice and what you do. And it can, but it shouldn't just be, well, I did this with this person or I saw this change, because we all know the, great grandma who smoked cigarettes every day and lived to 102. Like, that doesn't mean we would recommend that because we have this N of 1 experience. And like Chris said, it can be some of that anecdotal evidence is fine if, once again, maybe it is guided by the research, or maybe it is a little bit more logical in nature, meaning that, let's say one of Chris's mentors was a strength coach and he worked with people for 20 years. And he said, you know what? I usually have people work up to 20 push-ups before I start adding a weight vest on their back. And Chris says, why? And he goes, well, I've been doing this for 20 years. And I just find that when they're able to do 20 body weight push-ups, and then I add a 10-pound vest and they're between this body weight, they're able to do about 8 to 12 repetitions, and they can do so with the same form that they were using before, right? There's no evidence to suggest that that's true, but it's something that you could go, okay, that's believable enough. And maybe your progression would be 25 push-ups and somebody else's would be 15 push-ups, but it's logical enough that it's reasonable in nature, versus something that's just said that's unfalsifiable. Like, hey, someone had, toe pain and I had them bite down on a popsicle stick while, moving their head left and right, and they're breathing in and their toe pain decreased. And so that's what I do with everybody with toe pain. It's like, we're leaping quite a bit there.
Yeah. If they come across more as these magic tricks of look at this for this result, or let's get XYZ position, and then they're going to have significant improvement in symptoms, and it comes across more as a magic trick, then I think that's where the skepticism should be. But like Mark said, if it's this practitioner with just a ton of experience, they're like, this is what's really worked with these progressions or with this kind of model I've had, but I don't have anything research wise to support it. I think that's a very valid place to be, or to kind of come from. This second one, I think there's a lot of overlaps with these, but I just put experts on topics. So an expert, sometimes that's hard to define, but if you're taking a course on ACL rehab from one of the leading researchers on ACL reconstruction, then I think you're in a pretty good spot to have some level of confidence or comfort knowing that what's being presented is probably pretty valid and reliable information. And I mean, I'll plug like some of these master classes, whether it's Physio Network or Sports Map or these others, where they bring on researchers and clinicians that just go deep on one specific topic or one specific injury. And that's what they've researched, or that's the main group they've worked with their entire life or a big part of their practice. I think that can provide some comfort because they're well published in that area, or this is the main group that they've worked with. I think there's stability and confidence in that. And when you get into some of those niche, or not niche, but more specific areas, it becomes less about this, oh, I'm taking this course for this modality or this intervention that's going to cure or solve all of the patients that's coming in. I think once the courses become more and more broad and start trying to utilize these interventions or these beliefs for every single, diagnosis or pathology, that's where it gets really messy. And I wrote that in one of the other examples of like looking for a course that's not trying to solve all the ailments. And I think a lot of these groups try to do that, where we're seeing these patterns in individuals, or we're looking at these quote unquote faults. And no matter what they're presenting with, whether it's knee pain or hip pain or neck pain, like this will solve all of the things. And I think it's looking for courses that are maybe much more funneled in what they're discussing and what, pathology or body region or course that they're trying to establish. Do you have any thoughts there, Mark?
I'll push back on the experts on topics a little bit because, well, one, I would just say that you should, even if you are speaking with or listening to an expert on a topic, you should listen with the same skepticism that you listen with anything else. And the reason I say that is because sometimes I do find that the, let's say, very, very niche experts on topics who have been doing this for a very long time, and maybe they work with a lot of people with a persistent issue, that then they also start looking for the answer or the fix, meaning that, hey, this person has, let's say, Achilles tendinopathy, and it's been unresolved for a year or 2 years. And it's like, okay, well, what else could it be? Which is a fine thing to think. But I think when it becomes like this hyper specific thing that nobody else can assess in clinical practice, requires, very special imaging modalities, the management isn't necessarily any different. Like, those are the things that I go, okay, well, maybe this hyper specificity isn't that beneficial. So there is some skepticism from me sometimes when people only do one thing and they just become so hyper focused on it. I don't know if you have seen that at all.
Yeah, no, I appreciate that pushback, and I agree. And as someone consuming this information, someone could call themselves an expert, or a lot of the population could consider that person an expert. For example, us bringing on Stu McGill, a lot of individuals portray Stu as this expert in spinal pain or low back pain. But you look at these other researchers and groups as a whole, nationally or internationally, of back pain, they would probably disagree, or a lot of his statements. So yeah, I think that expert comment on topics does get messy. And like you said, when it's these really, really hyper-specific problems, still being as skeptical, whether it's, an expert talking on it or just someone that has more of a broad base. The last thing I put was kind of uncertainty and not speaking in absolutes. And this is what we just talked about as red flags, where if there's a ton of black and white and there's no nuance, then that's concerning. But if you're looking at groups or courses where these individuals are saying that there's still a lot of unknowns in this area, or these are some of the likely things to help, or this may provide improvement, or these are some steps or strategies you could do, it's just, again, giving that caveat of, you have options, or this potentially could work, or this is what we currently know. And it's not speaking as this is the truth, this is never going to change, this is the only option. I think the people that are most respectable in fields are the ones that are skeptical themselves, are aware of where kind of the current research stands, and are open to change, and are also understanding of the things that are still unknown. Do you have anything to add with that, Mark, or any other things with courses to think about?
No, I think we covered most of the big rocks today.
Cool. Yeah, I think to summarize, especially as a younger student or clinician, there's so much information to take in, and it can be really hard to know where to go and who to learn from. But thinking through some of these kind of checkbox items when you're listening to someone, or you're in a presentation, or you're in a course, and then just reflecting on it and seeing if your mind changes over time and with multiple other perspectives and education opportunities. And again, we're not saying that you shouldn't take these courses, or you should only learn from XYZ people. It's just having a base level of questioning and skepticism with anyone or any group you're learning from.
And we recommend applying that same level of skepticism to us and our information.
Totally. Yeah. We are always open to feedback or pushback on any of these topics.
But we prefer 5-star reviews.
100%. Yep. If you all like these debunking episodes, let us know what other topics you'd like for us to hit on. We'll call it there. Thanks, Marc.
Thanks, Chris.